especially for women, progesterone is so important for mood because it affects GABA receptors in the brain. And when you have low progesterone levels, you're going to feel anxious and you're going to be depressed. You're not going to sleep well. And when you're young, you're thinking, what's wrong with me?
Right.
And you go to the doctor and they give you birth control and antidepressant.
Right.
Our kids being put on 10 different medications nowadays for ADD, ADHD, anti-anxiety, antidepressant medications. Food is important. Exercise is important. Obviously, iPhones don't make it easier either, TikTok, but hormones.
Yeah.
Those hormonal fluctuations, and if we don't produce adequate amounts of hormones.
Right. It's sad. Hey there. So in today's show with Elana Zinkov, we take a deeper dive into managing and optimizing hormonal health for women. Men will still get value from this conversation, but we speak specifically about optimizing the transition off oral contraceptives, specifically hormonal birth control, optimizing the transition from perimenopause to menopause to postmenopause, optimizing sleep, optimizing blood sugar health, optimizing DHEA, and much more. So today's show is brought to you by our friends over at myoscience.com. The Myo Relax and Calm is a great nutritional strategy to help optimize sleep and help to manage hormonal levels throughout lifespan for both men and women. This product features myo-inositol, which is a B vitamin-like compound that's been shown to help optimize hormonal levels, along with magnesium, L-theanine, GABA, taurine, glycine, and potassium. This is an all-in-one solution that can help support metabolic health, hormonal health, and help foster a deep restorative night's sleep, along with electrolytes. It's a really unique combination formula that tastes great. There's hundreds of reviews over at myoscience.com. You can save with the code podcast over at MYOXCIENCE.com. I will put links in the description below. I really hope you enjoy this show with Elana. I learned an absolute ton. I think you'll find the show notes very applicable for following along. Those will be linked below as well. And without further ado, let's dive into the full episode. Interesting. I definitely want to get into hormones and pellets and subcutaneous versus transdermal versus all that. But maybe let's start off with this premature ovarian failure. This is a trend where a lot of young women are having menopause-like symptoms. I mean, as early as like 17. Have you dove? It's amazing the media coverage on this. There was a TikTok star, an actress, or a singer that said, "I'm going through menopause," and she's like 23 or 24. And I went to the academic literature, Google Scholar, PubMed, and surprisingly, there's a dossier of literature finding that this is a common trend. I would love to hear your thoughts on maybe why this is occurring and then what can people do about it? Why do you think it's happening?
Yeah, absolutely. Well, there's a number of reasons. Number one is we have the birth control pandemic. A lot of women, young girls, young women are being put on birth control for a variety of reasons, and birth control not being one of them. Yeah. The other reason is, of course, our environment and exposure to xenoestrogens from plastics, makeup, water. So there are a number of reasons that women are now going into perimenopause and premature ovarian failure at younger ages. And the number one thing I would recommend is just to educate women of when is it a good idea to be put on birth control, and that there's so many different options for birth control. There are non-hormonal issues, because what happens when women are put on birth control, we suppress ovulation. And when we suppress ovulation, we also suppress our own production of estrogen and progesterone. So effectively, our ovaries stop remembering what they're supposed to do in the first place. And what happens when women are on birth control for such a long period of time, when they come off of birth control, they might experience symptoms of early perimenopause, including weight gain, brain fog, acne, and absence of menstrual cycle. So I think reevaluating why we're using birth control, for what purpose, as well as what type of birth control we're using is critical. And the other thing that we need to do is, of course, reevaluate our food, organic versus non-organic, and our exposure to xenoestrogens. So this goes everything from skincare to produce to the quality of air and water.
Right. It's crazy. Even clothing, furniture, there's flame retardants. There was a mandate or some rule that all furniture had to have flame retardants. Bedding, I mean, kids, stuffed animals. I mean, these endocrine disruptors are ubiquitous in our environment. So I'm a huge fan of sauna and exercise for these reasons. But going back to the birth control, the sort of related analogy that I think about, it's pretty well characterized that when men go on exogenous testosterone, the testes will stop producing testosterone and they will atrophy over time. Is that sort of like, does the ovaries or the ovarian follicle, the follicles really, do they start to atrophy insofar as, because there's this exogenous source of synthetic estrogens, which are different from your own estrogen that you make, and then progestins that are different from natural progesterone. So is that sort of what happens essentially, or is it slightly different when people are on birth control for a very long time?
Slightly different, because even with exogenous testosterone, for example, your glands will naturally reduce the amount of hormone that they're producing. So this goes along with even thyroid hormone. When someone initially gets placed on thyroid hormone, the thyroid glands, there's a feedback loop. And so the pituitary will sense, oh, we've got thyroid incoming. So therefore the thyroid, it'll tell the thyroid to stop producing as much thyroid hormone. So there's a natural feedback loop that's in place. And it goes back to the ovaries and also the testes as well. So whenever we're doing exogenous testosterone therapy or even bioidentical hormone replacement, there will be this effect where the gland can kind of take a seat back and go a little bit on a vacation and not work as hard. And that is something that we need to take into consideration. So when we do go on these really high doses, and I would say super physiological doses of hormone replacement, there is risk for atrophy and also inability to produce our own natural hormones to the same extent or the same capacity. Synthetic hormones, I don't know if I would use the word atrophy, but they affect the physiological production of the hormone. So when women come off of birth control, it's going on hormone replacement can help the body recuperate, sort of speak, because you're not able to produce estrogen and progesterone on your own because that function has been suppressed, right? And so, but synthetic hormones don't even work the same as bioidentical hormones.
Right. They're hitting different receptors or acting differently or have...
Right.
The pharmacokinetics of these synthetic hormones are quite interesting in that they don't bind to sex hormone binding globulin. They can augment all the receptor functioning. I think that is a fascinating aspect that is under-recognized that a lot of people ought to consider. So what I heard you say there that I think is a really good tip for people that are women specifically that are trying to get off hormonal birth control is they might benefit from bioidentical hormones initially to bridge that transition for the lag time that their own hormonal pathways might need to kind of resync.
Yeah, absolutely. So there's a couple of different ways to approach this. Let's say I have a 24-year-old female who's been on birth control for maybe 10 years. She's young enough to where I think we could even pursue more natural therapy like phytoestrogen, herbs or seeds, phytoprogesterone, herbs or seeds, and we can effectively stimulate, not necessarily the production of those hormones, but we can activate and stimulate those receptors for estrogen and progesterone. Whereas a woman who's, let's say, 45 years old and who's been on birth control for 20 years, it's going to be really hard to get the same benefit. And I like to bring in bioidenticals, not necessarily estrogen, but at least progesterone and maybe even testosterone to get the benefit from these hormones.
I like that you hit on testosterone because many women and men think that this is a male dominant hormone, but women obviously benefit from testosterone, need testosterone, and the oral contraceptives and hormonal bearing IUDs, the progestins inhibit testosterone and and are linked with lower testosterone and thus probably lower libido, decreased sex drive, muscle mass, the whole thing. So in your practice, you focus a lot with women. A lot of women are attracted to the work that you do. Testosterone's a big part of what you work on.
It's huge. We got it so wrong in medicine because we think that women should be pigeonholed into how much testosterone they should have and that women don't need testosterone. Where if we actually look in lab testing, in proportion, we actually have more testosterone than we have estrogen.
Interesting.
And I actually think that testosterone kind of gives women that superpower, the ability to do so many things, the ability to juggle the household, the career obligations, to wake up in the middle of the night, all of those things. It's a really important hormone for motivation, for lean muscle mass, for cognitive function. And I think it's been a disservice to women to say that they either don't need testosterone or to just look at a range and say, well, your testosterone is a 10. So technically you kind of fit in that range.
It should be low anyway.
It should be low anyways. Mm-hmm. Oh, and by the way, that excess facial hair is probably due to too much testosterone. So we're going to throw on some spironolactone and suppress it even further.
It's crazy. That is prescribed so much, I'm learning. Yeah. And do you think the confusion about testosterone for women comes from the fact that like doctors, family medicine, internal medicine doctors, generally speaking, that aren't aware with all the nuances of nutritional biochemistry like you are, see high testosterone and PCOS. So then they think that, high testosterone must mean things are bad. So therefore we should lower it in women. Is that where the confusion?
I think in general, many healthcare providers are just not educated enough about even what's going on in PCOS. PCOS is not a testosterone issue. It's not really an estrogen issue. It's an issue in insulin. And it's an issue with generally lower progesterone levels. So there is a hormonal component to it. We're just not targeting the right hormones. And I have a lot of women who'll come to me and they say, well, I have PCOS because I have high testosterone levels. And I look at their testosterone, it's like at a 40.
Not high by any
And I'm
means.
like, it's not high, it's healthy. Those are very healthy testosterone levels. And they might even have normal or even optimal estrogen levels, but their progesterone is low and they've got insulin resistance.
So we're sort of looking at the smoke, not the fire. And the smoke would be the relatively high testosterone in relation to other hormones. But the fire is really the insulin and the hyperinsulinemia that's driving these hormonal issues. And so at the core of PCOS, the insulin is driving the low progesterone. Is that part of the problem?
So what's happening is insulin is really interesting because it's generally pro-inflammatory. So when we're looking at ovarian function, even if we look at a lot of the supplements out there for PCOS, it's inositol, glutathione, CoQ10, vitamin C, major antioxidants that help to reduce oxidative stress and reduce inflammation.
Yeah.
So whenever there's inflammation in the body, and insulin, in particular is horrible, like prolonged elevated insulin state, it will affect negatively ovarian function. And that in turn, will affect progesterone production as well.
Right. And so I have a better understanding. I want to get into DHEA a little bit, but so for men, the testes are making testosterone. Mm-hmm. In women, most of the estrogen and progesterone are coming from the ovarian follicles.
Yes.
Okay.
Mm-hmm. And adrenals
as well.
So yes. Okay. So for women and for men too. So men have adrenal glands too. So, but in talking about women, predominantly our ovaries produce estrogen and progesterone. And then our adrenal glands also produce estrogen, progesterone, and testosterone. So when a woman goes into, let's say, premature ovarian failure or menopause, we still have the adrenal glands that can help with sex hormone production.
Mm-hmm. Yeah, I want to get into that with special emphasis on DHEA in just a moment. But to help understand the hormonal transition into perimenopause or premature ovarian failure into menopause. So the number of follicles starts to diminish over a woman's lifetime. Mm-hmm. During their prime reproductive years, there's many follicles, and then we see a high AMH. Do you look at AMH and then start to see it decline?
Yeah.
So can you speak to that? Because I think a lot of people in their 30s are starting to think about children now. Like, okay, I want to have kids. I met my person. I want to, start to think about a family. Maybe I'm getting off birth control in this. Do you look at AMH, and does AMH levels, I've tried to look at the literature on this with regards to birth control, hormonal birth control specifically, if that drives down AMH. Have you looked in, I couldn't find research either way, but
yeah,
maybe.
So AMH is really interesting because there's so many factors that can affect it. And for those who are not familiar with the AMH, it's effectively our way to look at the ovarian reserve. The ovarian reserve reflects technically the number of viable eggs that a woman can have. And we're born with a predetermined sort of number of eggs. So some women will be really upset when they get a low AMH, which is indicative of a lower ovarian reserve. And some women will celebrate when they have a really high AMH or a higher, I should say, or optimal AMH, because they think like, oh, I have a great egg count. But we should also be focusing on the egg quality, not so much just the number. So quantity when it comes to AMH, bigger does not mean better.
I see.
But when it comes to birth control, that's a really interesting question, AMH and birth control, because technically, there's certain drugs that can slow down the release of eggs. And with birth control, especially if you're suppressing ovulation, technically you can have a higher AMH over time, but quality.
I see. So the follicle quality goes down even though the AMH could be high. Because the
Absolutely.
Okay, that's a good differentiation.
Yeah. The things that are really important for quality of the egg. Estrogen, we don't want it to be too high or too low. Testosterone actually improves quality of the egg. And I have a lot of women who are in their late 30s and early 40s who are just now thinking about freezing their eggs. And I'm like, we have to get on DHEA. We have to get on testosterone to help improve the quality of the egg. We might not be able to control the AMH number, but we can control the quality.
Right.
And I love there's someone who I follow, and she's an acupuncturist and nurse practitioner. And she likes to remind women, you only need one egg. So what your AMH is low? Right. You only need one egg to have a pregnancy.
Right. I think that's helpful for people to hear,
Totally.
because that could be scary if the number is low. Then you think doom and gloom, I have no viable eggs. But like you said, there's, millions. Maybe, are you born with billions, or it's probably tens of millions of follicles, eh?
It's about, on average, I think it's about 1,000.
That's it.
Yeah. And then it slowly starts to decrease. Every ovulation, every menstrual cycle, it goes down. Mm-hmm. So what happens with ovulation is you have a release of an egg, which is why I'm thinking with birth control, because in some women, especially on birth control, that suppresses ovulation and you don't get your period. If there isn't a release of an egg, then you have
a lot of eggs.
But
because the hormones are imbalanced, the quality might be a little off.
And they could be living a really poor lifestyle. You could be obese and have a really good AMH, but the quality of your eggs might not be that great.
What's interesting about this conversation is it seems that testosterone is so important for fertility for both men and women, because we're seeing that low testosterone with diabetes and obesity is a primary driver of male infertility. And then we're talking now about the importance of follicular health in women, and you're just articulating how important testosterone is for females as well. And so I think, this is really helpful to kind of reframe this away from just being a male predominant hormone. So I think that's very helpful. Another anabolic hormone that you mentioned is DHEA. It's funny, Elana, a lot of people get DHA, the long chain 22 carbon polyunsaturated fat from algae and fish, confused with DHEA. Let's talk about where DHEA is made and so forth, why it's so important for women, and how do you like to dose this? Orally, transdermal, suppository, etc.?
I'll say a couple things about DHEA. So first of all, it's produced in the adrenal glands, and it's very important for women. A lot of women will notice that when they are experiencing low energy, generally their DHEA is on the lower end. When women go through periods of heightened stress, I'll actually see high levels of DHEA via serum testing. And I think one of the reasons we see that is because you kind of go into this hyperadrenal mode where you're producing tons of cortisol, and in order to get to cortisol, then we need DHEA. So we're seeing just this natural occurrence happen. So we'll see high DHEA, but then we can't keep up with stress and chronic stress, and then we see this drop in DHEA. And a lot of women in perimenopause and menopause will see lower levels of DHEA. DHEA is important. It doesn't necessarily, I know there's mixed views about conversion of DHEA. I don't really see it convert to testosterone. And I know that there's a really small chance that it can, and it's really individuals. The majority of people I see it convert to estrogen. And in some people we can't get it to convert to testosterone. But DHEA, from an energy perspective, even from keeping estrogen levels really healthy is really important. Blood sugar metabolism, muscle mass, recovery post-workouts. It's a really important hormone. And I see good benefits just even with oral supplementation. If for whatever reason we can't get the levels high enough with oral, then we can do transdermal cream.
Nice. Yeah, even immune system. I mean, during COVID, I was talking about DHEA a lot. There was a few different studies that have shown that people with low DHEA have compromised immune systems. The phagocytic capacity of their white blood cells was reduced. But I'm glad you mentioned blood sugar control, because in diabetics and obese individuals, there's noted associations with low DHEA and blood sugar stuff. So yeah, it's just profound. And what I love about any of these therapies that we've been talking about, you mentioned myo-inositol for PCOS, dirt cheap. I mean, this is very affordable, right?
Absolutely.
DHEA is one of the most affordable supplements you could buy. So it's not like it's one of these very expensive things like NAD or NR or NMN where people have to spend $100 a month. I mean, we're talking about low cost things that improve multiple systems at the same time, which is why I'm a huge fan of that. Okay, so oral. Now, women obviously would benefit from less DHEA than men. And I know you like to test DHEA sulfate. Is that what you in the serum?
Yeah, absolutely.
What would be a starting dose for someone in their mid 30s or early 40s for a woman?
5 milligrams.
Low.
Yeah, you want to start low. And that's always been even my approach with any hormone is you want to start low and you want to go slow. And with women, one of the reasons we want to start on a lower dose is because we don't want them to get acne. Because if they're converting DHEA to estrogen, then they're more likely to have some of those estrogen dominant like symptoms like acne. So it's a really common side effect. Oily hair, that's another common side effect. So I usually start on 5 milligrams and that sometimes is enough. And some of my women who are like super metabolizers, they're like on 25 milligrams of DHEA. But, we test every 8 to 12 weeks and we see what their absorption is. And one of the things that I'll do is if I notice that the levels keep increasing the dose, but it's not moving, is I'll have women take DHEA the night before and then we'll retest it in the morning, and it was just a timing issue.
Right. Let's get into timing of that. When I first got into DHEA like 5 years ago, I was taking it in the morning. I read some literature finding that it sort of antagonizes cortisol production. I was like, well, I want a strong cortisol awakening response. So I've been taking it in the evening. What have you found clinically to work best in terms of timing?
Yeah, I do think that DHEA is better to take in the second part of the day. And clinically, just even from my patients, I do prefer that people take it in that second half. Around dinner time is fine. It's not going to affect your sleep. In fact, the opposite. It'll match the circadian rhythm, like you mentioned. Even that cortisol curve, it's supposed to we're supposed to have lower cortisol levels in the second part of the day, just naturally. And so I think DHEA works best in that way.
Yeah. What's interesting about this is I've dove a lot into cortisol and the cortisol awakening response and things like that. We haven't really talked about it on the podcast specifically, but as you get older, cortisol should go down. And we want a higher ratio of DHEA relative to cortisol. And so that's kind of interesting that, that ratio actually determines sleep quality. It was interesting in one elderly study. So I think it is important, you mentioned sleep, and we're going to talk about sleep in a moment with perimenopause and menopause, because that obviously is a major issue with women. If someone could solve that issue, they'd be like a billionaire.
That's what I'm trying to do.
There you go. I like it. But one piece of low-hanging fruit, I think, is DHEA.
Yeah.
That relative ratio has been shown in multiple studies to improve sleep quality.
Yeah. I think it's important to look at a number of ratios when we're thinking about hormones. There's the DHEA to cortisol, estrogen to progesterone, for example. That's another huge ratio. Just like with nutrients, we want to make sure that, what's the ratio between copper and zinc. So same thing with hormones. Looking at the ratios is really important. But I would say even as we get older, growth hormone production declines. So we might even nail our DHEA to cortisol ratio. But if we don't improve our growth hormone production capacity or ability, whether naturally through exercise and fasting or supplementation, like with peptides.
Yeah.
Then we're still going to have problems with sleep and recovery and muscle loss and all those other things that
fat gain.
Yeah, exactly.
Let's get into that. I think talking about growth hormone now is a nice segue because I want to get into perimenopause and menopause shortly, and this will fit right in with that. How are you looking at IGF-1 to ascertain growth hormone levels, or more?
Absolutely. Okay. Yeah, because we can't, if we just measure growth hormone, it has such a short half-life in the bloodstream that we can't measure it accurately. Yeah. So the next best thing is IGF-1, derived from growth hormone. And a lot of times if people are at 120 or below, that's a sign of a growth hormone production issue. And it can happen for women at any age and for men as well, but it's really hard to have like high levels of IGF-1.
Unless you're like full-blown diabetic or something crazy.
Yeah, or there's something else. There's like, again, high levels of DHEA or tumor. No, I'm sorry, not DHEA, inflammation or prolactin, something that could potentially indicate that there potentially issues with pituitary.
Yeah, which are uncommon.
Yeah, and they're usually benign, but that's usually one of the first places that we go to.
Right. So you look at IGF-1. Now, is this in the morning fasted?
Yes.
Okay.
Morning fasted before 9 a.m. Naturally, all of our hormones are at their peak between about 8 to 10 a.m., which makes sense. So we can try to biohack nature all we want, but there is a peak in our hormones. And I try to get people to the labs before 9 a.m. fasted.
Nice. And you're looking at that. So what does your panel look like? You mentioned insulin, so you're looking at insulin.
Absolutely.
And do you like to first rule out serum hormones before getting into urinary or sublingual or salivary?
Yeah. So I love to do a combination of tests.
Okay.
Blood testing or serum testing is the gold standard. It's kind of the common language that unites us among different medical professionals, but it's also still the most accurate. So serum blood testing is still the most accurate, and we can test a lot of things where there are certain limitations to salivary testing or urine testing. And one of the benefits of serum testing is that this is something we can use long-term to monitor therapy outcomes. Whereas we can't do that really with salivary or urine testing. Once someone starts, let's say, hormone replacement, we don't want to use urine testing, or salivary testing to monitor the levels of hormones in the body. And so I start with serum blood testing, and I get a whole panel: nutrients, hormones, metabolic markers. So we want to get the whole picture. And then I will use urine testing for cortisol and estrogen metabolites. Salivary testing is tricky. Some people prefer salivary testing for cortisol, but there's just way too many false positives and false negatives. Our mouth is just this complex place where it's like there's too many variables that can affect it.
Right.
Yeah.
And so do you like Precision Analytical, the Dutch Plus test? Is that what you'll go to for more urine?
Yeah.
Okay.
Yeah.
And you said estrogen metabolites, the 16-OH, 2,2-hydroxy.
And 4-OH.
4-OH.
Yes. So what we're looking at is also the ratio between the 2-OH, 4-OH, and 16-OH. And honestly, there's a lot of debate in the medical community and the research. We used to say that one is more pro-inflammatory than the other, and that it can show detox pathways 1 and 2, how well they're working, if there's a backup. In all honesty, it doesn't really matter what your estrogen metabolites are. You still need to focus on liver health. You need to make sure that you reduce your exposure to xenoestrogens. And if you are on hormone replacement, you need to make sure that you're not just on estrogen, that you're buffering estrogen with progesterone, and that you are testing your levels to make sure that you're not in these like super physiological doses of estrogen. Right. So it's, as much as I love looking at those estrogen metabolites, what is that information? What am I going to do with that information? I'm going to have to focus on improving liver health, detoxifying, and making sure that the person is healthy overall.
I love that. I want to get into specifics of that. Maybe at the end we can talk about your favorite liver supplements, NAC, glycine, glutathione, all that.
Absolutely.
But how would you tell if on blood work that someone is having premature ovarian failure or is in perimenopause, early menopause? What would you see in it? We talked about AMH and we might see that decline, but not always. But what about the relative ratios of testosterone to progesterone to estrogen? What would you start to see?
I love that because this is what I do day in and day out.
Nice.
I love data and I look at data all day long, and I'm able to communicate to women based on the symptoms and the labs and let them know where they are. Are they having premature ovarian failure, or where are they in perimenopause? Is it early stages or late stages? And so what I look for is LH and FSH. And generally, if the FSH starts to climb above 15, and we're looking at the first half of the cycle in the follicular phase, we're looking at FSH. If it starts to go above 15, then that's the sign that the ovary is struggling in a way. Because what does FSH do? It helps the egg to mature, but it also stimulates the release of estrogen and progesterone. And earlier we talked about the feedback loop. So there's a feedback loop between the pituitary and all the other major glands, and of course the hypothalamus too. But if the ovary is struggling to produce estrogen and progesterone, and the pituitary is getting the signal that there's not enough estrogen and progesterone, then it'll increase the production of FSH. And that's why we start to see that peak in FSH and LH. So that's the number one, is that we're starting to see almost late perimenopause, menopause levels of FSH in women.
Over 15.
Yes.
More, so FSH is more sensitive or specific than LH in this context? Okay.
Yeah, absolutely. And we'll start to see low estrogen below 50, because the sort of an optimal range for estradiol is between 50 to, I should actually say 70 to 150. So if we're starting to see estradiol below 70, that's a sign that the ovaries are really struggling to produce estrogen.
Interesting. Can I ask a quick question here?
Yeah.
So with regards to estrogen, with serum testing, this is all contextualized to the first part of the cycle.
That's a really good clarification. So when I'm looking at fertility, yes. So the follicular phase, I'm looking at FSH and estradiol. When I'm looking at where a woman is in her reproductive age, let's say, or stage, I'm looking at the luteal phase, the second half of the cycle, because that is when we're supposed to see a peak in both estrogen and progesterone. And let me say this, more progesterone than estrogen. Estrogen will be a little bit higher than usual, but progesterone is supposed to dominate in the luteal phase. But I am testing estrogen and progesterone in the luteal phase in the second half of the cycle to see, well, how high does estrogen get? Or how high does progesterone get? And what I see in women, besides increase in FSH, actually, and I would say even in both follicular and luteal, is this decline in estrogen and progesterone.
And for people that aren't familiar with the vernacular, luteal phase, follicular phase, so if we start, time point 0 would be right when you're bleeding, or would that be?
So day 1.
Okay.
Day 1 is when you're bleeding, and then you have ovulation, which is like, for someone could be day 13, day 14 of the cycle. And then we're going into the luteal phase, which is that second half, usually after day 17 in a average 28-day cycle.
Right.
And so after day 28, day 1 is when there's bleeding.
Okay. So for fertility related stuff, it might be a week after your first bleed?
Actually, day 2 or 3.
Oh, early.
Very early. Because what we're looking at is actually, what is FSH? How high is it? And how high is estrogen? So in the follicular phase, a high FSH and a high estradiol, 80 or above, is actually a sign of poor egg quality. So, but I also like to test FSH, estrogen, and progesterone in the second half of the cycle, the luteal phase, because then that can tell me where the woman is in the reproductive stage.
Interesting. And you mentioned other birth control alternatives. This is probably a nice segue into those options. There's the Daisy app. There's all these temperature timing apps and things like that for women who are seeking to get off hormonal-based birth controls. Do you recommend looking at the ovulatory mucus and fluid in this, or using temperature app based measurements? How do you recommend a female who's been reliant upon these hormonal methods to then trust her own intuition and her body's natural ebb and flow to know, okay, this is probably not an ideal time to have intercourse unprotected if I don't want to have a baby right now? What do you recommend?
Yeah. So there's a few things. Number one, you have to get familiar with your cycle. Do you have a 26-day cycle, a 24-day cycle, a 30-day cycle? Because then that can shift your ovulatory period. Some women can have, again, like ovulation can happen on day 14, day 17. So it's really important to get at least 3 months data of what's happening. I wouldn't just jump on an app and then be like, hey, hon, let's do this. My app says that, it's go time. So you want to get at least 3 months of data and see how consistent it is. So are you ovulating on day 13 or the next month, day 18? So once you have that consistency in data, then we can do also body temperature, and absolutely cervical fluid is one of the best ways to know if you're ovulating, because it'll get thicker, stickier, something that will grab onto the sperm and make it stay effectively. So body temperature, cervical mucus fluid, and then tracking your cycle to make sure that you're regular. So if you are having fluctuations, let's say 1 month you're 26-day cycle, another month you're a 30-day cycle, then there's a little bit of irregularity that's happening, and I would work on that first. I would try to get your cycle to be more regular, which would then make it easier to track ovulation.
I see. And the way that you would work on that would be nutrition, lifestyle, sleep, stress management, all of those things.
Yeah, and potentially, depending on the age, it could be herbal supplements or it could be bioidentical hormone replacement. Okay. So again, are we talking about a younger woman, 20, 22, 23, 24, 30, or are we talking about a woman who could potentially be in perimenopause, 35, 40, or 45?
Yeah. For people that have their lifestyle really and their nutrition and exercise dialed, how much variation do you normally see clinically in cycle? Like going from 26 days to 28 or vice versa, all that? Or are people who are really living a healthy life and organic food and all the things, is it just like on point 28-day consistently?
No, not at all. And I think that's the demographic of women that I see. They're doing all the right things. They're doing the infrared sauna. They're exercising 5 to 6 days per week and not excessively over exercising. They're trying to take all the right supplements, but they're still having hormonal issues. And this is where I talk about this so frequently, that we can't always achieve things naturally by living a clean lifestyle. I mean, that's the experience that it was for me. I grew up as an athlete, but I know looking back as a teenager, oh God, I had low progesterone. But my mother, who's an MD actually, her solution was birth control. And I struggled with mood, and I struggled with bloating, and I had terrible acne growing up. But I ate salads and lean protein and was an athlete and was sweating daily, but I had a hormone imbalance that was most likely genetic. And overall, potentially just lower levels of hormones naturally. So for me, herbal supplements didn't really work that well. And in my early 30s, I started doing hormone replacement.
Interesting. I want to get into that, but you mentioned, look, in hindsight, 2020 is always more clear than, you mentioned that you suspect that you had low progesterone. You mentioned bloating. What other symptoms did you have that suggest that you might have had low progesterone back then?
Painful cycles. So I remember even being in high school and talking to my friends. They had to be on pain medication. So Midol, for example, even, and sometimes even heavier duty pain medications. So I had painful cycles. My friends had painful cycles, heavy bleeding, extremely heavy bleeding, almost hemorrhaging, like heavy bleeding, cystic acne. those were some of the signs of low progesterone and mood swings. So a lot of times, I mean, why are kids being put on like 10 different medications nowadays for ADD, ADHD, anti-anxiety, antidepressant medications? Food is important. Exercise is important. Obviously, iPhones don't make it easier either, TikTok, but hormones.
Yeah.
Those hormonal fluctuations, and if we don't produce adequate amounts of hormones, especially for women, progesterone is so important for mood because it affects GABA receptors in the brain. And when you have low progesterone levels, you're going to feel anxious and you're going to be depressed. You're not going to sleep well. And when you're young, you're thinking, what's wrong with me?
Right.
And you go to the doctor and they give you birth control and antidepressant.
Right. It's sad.
Yeah.
It's really sad when you look at the polypharmacy for psychiatric medications in adolescence and how many kids are being overprescribed all sorts of mind-altering medications paired with stimulants. I mean, this is a major epidemic. I'm probably going to get a lot of kickback for asking this question, but with regards to the recent surge in gender dysphoria, how much do you think that is hormonally mediated, from our environment and this? I mean, obviously there's the social contagion element of it and increased discussion of it, but from a hormonal standpoint, do you think that is influencing, people questioning their gender?
I think to some extent, yes. I think it's just our exposure to xenoestrogens, for example, for both boys and girls or young men and young women. When you have a flood of xenoestrogens that are endocrine disruptors, it can affect how you feel about yourself and your gender preferences. But having patients who have kids who have gone through this, I see it more as actually pressure from not necessarily society, but their group of friends, more peer pressure versus even xenoestrogens or anything else that's happening from the environment. In particular, I'm thinking about one patient who had her 13-year-old daughter wanted to be a boy because she did not feel comfortable in her own skin. And it was easier for her to show up as a boy to school. And there actually Children's Hospital was really pushing hormone replacement. And instead they chose therapy.
Nice.
To kind of talk about, it wasn't that they didn't want her to be a boy, for example. She can be whatever she wants, whoever she wants to be, right? Sure. But it was more about, was this going to be the right decision for her long term? Because there's certain things you can't undo later on. And it turns out that she was just struggling in her peer group. There were certain pressures from school, from her friends. But after going to therapy and talking about, being able to talk about it and being able to talk about what are the different ways that she can feel comfortable with herself, she actually decided she wanted to continue being a woman.
Wow.
So
that's a great story.
Yeah. So I think we just have to look at it from, of course, they're from a perspective of, there could potentially be hormonal issues, but we can't ignore what's happening in our society and our culture. Yeah. And what's happening in schools.
Yeah,
right?
It's pretty wild.
Yeah.
Thank you for sharing that. I know it's a very controversial, polarizing issue, but I think it's really pertinent. Anyone who has a middle schooler or high schooler is aware of this, and I think we should all be able to at least have a conversation about it.
Absolutely. And I have a number of clients. This is not me just sharing my bias or my opinion, because I will always just meet the person where they're at on their journey. I just think it's more complicated than I want to be a different gender.
Right. And especially these are lifelong decisions.
Yes.
Administering hormones before puberty and menarche, specifically in women, will have lifelong alterations to fertility, growth, all of that. So I think it's important to discuss with a therapist. So going back to progesterone and testing for this, I loved how you put language and give us some nuances and context there. When it comes to progesterone, we have topical, we have suppositories, we have oral delivery agents that help with sleep and so forth. So obviously someone needs to work with a practitioner like yourself and understand their levels. But what have you found clinically to be most effective, especially for sleep? With perimenopause and postmenopausal women, sleep is a major challenge. Do you find any benefit with oral progesterone?
Absolutely. It's one of the first things that I will start women on is oral progesterone. I will put women on a cream progesterone if they're very sensitive to oral progesterone. But especially with women in perimenopause and later stages of perimenopause, I find it to work extremely well, not just for sleep, but also for their mood. They'll go from feeling really irrational to now having more stable mood. So, and for some women, they can declining progesterone levels can impact not just how they feel leading up to the cycle, but throughout the month, irrelevant, where they are in terms of the day of the cycle that they're on. But bioidentical progesterone, oral supplementation is wonderful. We can also take into consideration immediate release or sustained release. So I sometimes call it instant release, and then my compounding pharmacists like to correct me that it's immediate release. But for some women who have, let's say, don't have any trouble falling asleep, but they wake up at 2 or 3 o'clock in the morning, then the sustained release can be a better option than the immediate release because they don't really need it that instantly.
Right. Okay. And this would be an oral sustained release. So it'd be like slowly drip out progesterone over time.
Yeah.
And talk about why the oral is specifically more helpful for sleep and the conversion to allopregnanolone. I think that's fascinating.
Yeah. So one, better absorption and faster absorption compared to topical cream. But not many people actually know that progesterone gets converted to allopregnanolone. And one of the major benefits is that it goes and attaches to the GABA receptors and stimulates GABA, which is why we have then that kind of soothing effect. With the topical progesterone, we can still get that effect, just not to the same extent. So if women are really depleted in progesterone, then I just suggest going straight to oral.
Okay. Nice. And allopregnanolone really helps with sleep because of GABA in this. What is it doing to help foster sleep?
So it stimulates GABA receptors.
Okay.
Yeah. So by stimulating GABA receptors, it has this more of a sedating effect, which is why it can help women sleep.
Interesting. What about theanine? There's, we mentioned inositol. There's taurine, there's GABA, oral GABA, all these things can be helpful for sleep. What do you think, in addition to the oral progesterone, is particularly helpful for women struggling with sleep issues?
Absolutely. So valerian root, you mentioned oral GABA. I think that works great. I don't like melatonin because I think melatonin is it's sedating, but it doesn't help you get the deep sleep that we need. CBD can be really helpful for women as well. Magnesium. I love magnesium. So just even the combination of like magnesium, GABA, L-theanine is wonderful. I like to dose L-theanine actually in the morning and before bed, because if a woman is struggling, let's say, with anxiety or nervousness throughout the day, then a lot of sleep issues we have to address what happens during the day as well. And so if we do like L-theanine during the day, then she's going to be less amped up leading up to bedtime, so that then when we dose L-theanine before bed, we have a better effect.
Nice.
Yeah, but magnesium, I was going to say, is, it's such an important nutrient to consider with sleep in women.
Totally. And also it dovetails into gut health. I think a lot of people are constipated, not having bowel movements in the morning. So magnesium can be super helpful there. Getting back to growth hormone, I don't know that we put a button on this conversation with regards to peptides. There's GHRP6 and Somorelin and these different peptides that can be helpful. So if we want to be science-based about this, we would test before 9 a.m. our IGF-1. If that is low, do the lifestyle things and everything like that. But if we can't bring up our growth hormone, where do you weave in peptides into that conversation?
Yeah. So let's even back up a little bit and talk about IGF-1 levels. So you could have even good IGF-1 levels, but the amount of receptors that you have to bind IGF-1 could be suboptimal. And this is where growth hormone releasing peptides or growth hormone releasing hormones come into play, because they will actually upregulate the amount of receptors that the cell has to receive the growth hormone. So we're essentially working on improving cell efficiency in that way. And a lot of like ipamorelin, for example, let's use that peptide. It'll actually stimulate IGF-1 release from the liver as well. So we can have growth hormone release effectively from multiple places. So yes, we can increase the levels, but we can also increase the likelihood, that it'll get to the cells and make the cell do what it's supposed to do.
Interesting. Now, do you pair these together or is it all contextual? I mean, what do you personally do in terms of these peptides?
Yeah. So there's what I do personally, and there's also what I prescribe. So I try to get my patients to stimulate their own growth hormone production first. Yeah. So for example, we'll work on fasting. Intermittent fasting is huge for growth hormone production. So there's no reason to bring on peptides if you haven't addressed nutrition, if you're not lifting weights, if you haven't addressed the hormones. There's just no reason to jump 10 steps and go straight to peptides. So we'll work on that first. And then if they're still not able to, let's say, get deep sleep or build muscle or burn fat, or they're still losing hair and they're not seeing the improvements in their skin, for example, then I'll introduce potentially, now ipamorelin, it's on the FDA sort of category 2 list. So, but let's take sermorelin, for example, and testosterone. Those are grandfathered in, so they're safe and we can use those. Then I'll prescribe sermorelin, and preferably in injectable form. That's always most effective, but there's also troches, and then there's nasal sprays nowadays for those who are kind of scared of the needles before bed. I personally, I used to love the CJC family and the ipamorelin pair together because we want the growth hormone releasing hormone and the peptide working synergistically. But, even right now, since we can't do that, given the FDA ruling, I do like to use sermorelin, and we can still get really good results.
And how quick I've never taken peptides. I'm curious about it. I'm 41. I noticed recovery is not quite as good. It takes a few more days for me. Sometimes if I lift heavy, I'm like, why am I still kind of sore? So I'm just curious about this. Is it 3 months time, 90 days?
Eight to 12 weeks.
Okay.
Yeah. 8 to 12 weeks. Yeah. They are peptides. They work slowly, but they work. And the cool thing is that they have such amazing physiological benefits. It's like you're taking something and the reason why they are really anti-aging is because they actually improve cell efficiency and cell function. So we're able to reduce metabolic disease, and we're able to improve muscle function and fat loss. So preventing cardiovascular disease and diabetes and all of these things, but also improving brain function. So one of the things that goes out the window is sleep, like we talked about sleep. And that's usually, for a number of reasons, including declined progesterone. Actually, testosterone is really important for sleep as well. And so that's one of the things when actually women go on pellets and they have this spike in testosterone where, we get them to pretty high levels. It's like one of the best sleep of their lives. Wow. Yeah. But with declining growth hormone levels, you hear about 75, 80-year-olds who just wake up at 2:00 in the morning and they start the day because they can't sleep. If we just put them on some growth hormone peptides, they'd be able to sleep through the night.
Interesting. Now, with these peptides, are we getting exogenous suppression? Because for example, if we were to both start taking exogenous growth hormone subcutaneously, we might suppress our natural levels. With the peptides, I don't believe that's happening, right?
No. Well, and there's a difference between HGH, human growth hormone, which is synthetic. So just like with hormones, actually, HGH is terrible in terms of the impact on insulin and cortisol. It is not something that we want to stay on long term. Whereas sermorelin peptide, for example, that's a bioidentical agent. So there's no suppression that's happening. We're making the glands produce growth hormone and IGF-1, and there's no suppression. No negative impact on blood sugar or insulin or cortisol.
And how much are these peptides if someone wanted to get into this?
This is where it does get pricey.
Yeah.
So, and it depends on the clinic. It depends on what the clinic is getting charged. It depends on the compounding pharmacy, but anywhere from $400 to $500 a month.
So they're pricey.
They are pricey. Yeah. The good news is that you don't have to stay on it forever. It's good to do it in cycles. So peptides are awesome because if you do an 8 to 12 week cycle, you can take a little break and you're not going to lose the benefits. That's the awesome part. Testosterone, if you don't apply it, you're not going to get it, right? You're not going to get the benefits. Whereas with the peptides, because they overall improve physiology of the cell, you're getting those benefits even when you stop, which is why we see the benefit even with a lot of the psychiatric peptides like DHEA and Samax and Selnac, which affect dopamine and serotonin producing neurons, is that we cycle them and we're not even supposed to be on them long term. So we do see a little bit of like, let's say, receptor
expression enhancing.
Yeah, we do see some issues when we're saying long term on those peptides, but that's why we want to cycle them 6 weeks on, 6 weeks off.
That's smart.
Yeah.
That's pretty cool. With those psychiatric peptides, this is totally new to me. I would think they would be helpful in addiction contexts, people that maybe have an alcohol addiction or whatever else. I mean, is that, or depression, all that?
Absolutely. So ADD, ADHD, anxiety, depression. Unfortunately, the peptides that I just mentioned, as I mentioned this, I realized that the FDA is also is not excited about them. The reason why they pulled them is because they just want more evidence. They want more physicians like myself to provide the evidence that they're working and they don't have negative side effects compared to some of the other peptides. But there's a ton more that we can use to improve cognitive function, like oxytocin, for example.
Wow.
So this is the cuddly hormone that's released during intimacy. But actually, oxytocin nasal spray is very neuroprotective and can help with stress management, stress resilience, so better response to stress and anxiety and depression.
Wow. It's interesting the FDA is all over peptides, but they endorse other things so easily. So that it's crazy to me. Anyway, conversation for another time. Elana, so
they should put Skittles on that list.
They should. Yeah, there's so many things I can think about that are unhealthy. So what was your sport of choice? So in high school, you said you were an athlete. Tennis. Okay.
Yeah, I was a huge tennis player.
Right.
5 to 6 hours a day.
That's a lot. Okay. I don't, we follow each other on Instagram. I don't know where you stand when it comes to diet. For women specifically, is there a type, more of a moderate carb diet, paleo style, grain-free, gluten-free, carnivore? Where do you land on that spectrum?
I love protein. And I encourage women, especially as we get older, to emphasize protein in their diet. So I always say lead with protein. If you have room after 30 to 40 grams of protein to eat potentially whole grains or leafy greens, then go for it. But I really like to focus on at least 30 to 40 grams of protein, so bolus form of protein. And there's so much research to show that that's what we really should be eating at least 3 to 4 times per day. So, and good sources of protein. It's hard for me sometimes to work with vegans and vegetarians because we just, it's so hard not, to get adequate amounts of protein and all those branched chain amino acids, from not from animal protein, still workable, but you just have to then supplement a lot more. Always talking about limiting processed carbs. Processed sugar. Obviously, life happens. You go to a party or around the holidays, but we really want to make sure that in terms of even carbohydrate intake, it's rocket fuel. And I like to say that, unlike rockets, we store that fuel as fat. And so unless you are training every day, we want to make sure that we are limiting the amount of grains, whole grains, preferably gluten-free, because gluten it's pro-inflammatory. We want to reduce inflammation. And we want to double down on healthy carbohydrates, squash and zucchinis and tons of leafy greens, and keep our fruit intake at a minimum.
Okay. That's recent. Nice. And a lot of people are now talking about a gram or 1.6 grams per kilogram of protein per lean ideal body weight. Do you recommend something along those lines, or? Yeah,
usually a pound. So a gram per pound.
Is that what you? Okay.
Of body weight, and that can be hard for some women. So let's say you take an average, like 150-pound woman, for example. It may be hard for her to eat 150 grams of protein, and she might not be able to even tolerate that much because if they're not as active, that demand for protein is not really going to be there for, muscle protein synthesis. And so once I get them to exercise more and to lift more weights, and I mean, they're ravenous for protein. And so it's much easier to get them to eat that much. But I say minimum of 120 grams of protein per day.
Nice. I like that. Amazing. Anything that you wanted to talk about that we didn't get to? I mean, we covered a lot of bases here. Maybe we can talk about thyroid a little bit later.
Yeah.
But I would love for folks to be able to know where they can connect with you online. And you do a lot of virtual consulting as well.
Yeah. So I'm huge on Instagram. I love sharing tips. So they can find me on Dr. Elana Zinkov on Instagram, and then connect with me on drelanazinkov.com.
Nice. I love that. And so you were born in Russia. When did you move to the US?
I was 9.
9. Okay.
Yeah.
Do you go back to Russia ever, or?
Not now. You can't you can't really go back since COVID. COVID and then the war. It's hard. Yeah. I keep wanting to go back, but then something happens. I wanted to go back, and then COVID happened, and then I wanted to go back, and then the war happens, and now you just, it's really hard to just go.
Right.
Yeah.
What's a lifestyle habit in Russia that would make people healthier? I know there's a lot of banyas, sauna, people grow their own vegetables and foods and things like that. What's a habit or tradition that makes Russians kind of more resilient, would you say?
I think 2 things, probably seasonality. So especially when I was growing up, like we didn't have access to fresh produce year round. So there was seasonality element. We had a lot of fermented vegetables, fermented fruits. And then when it was summertime, that's when you go to the markets and you're getting the grapes and the watermelon and the berries and everything. And a lot of it was actually imported from other countries during that time. But, fermented foods as well. One. Yeah.
And in your household, how often are you eating fermented foods? Is this a staple?
I mean, daily. I used to have a dairy allergy. Dairy sensitivity. I didn't have a flat out allergy to where I couldn't have it. It would make my skin break out and would affect my digestion. And I took out dairy for probably about 10 years, and I was able to introduce it back in and not have a negative reaction. And so we love our full fat Greek yogurts. We also love our sauerkraut and kimchi. So we do that pretty much on a daily basis.
And borscht is a pretty popular Russian dish.
Oh, I love that. I mean, I just cooked it like the other week.
Nice.
Yeah. And so borscht, classically you add sauerkraut to it.
So it covers both bases. Yeah. Okay.
Uh-huh.
That's amazing. Yeah. Russian food is fantastic.
It is.
Quite like. So ferments are like kind of when you go to Asia, I've never been to Eastern Europe or Russia or Ukraine or things like that. But in Asia, obviously ferments are staple, so that you're having a little bit kimchi or sauerkraut basically with every meal. Is it the same sort of in Russia?
It is. Yeah. It's interesting. I wouldn't view Russians as the healthiest of people. I think their resilience comes from just our culture and the things that the grits. I would describe our resilience as grit and the things that the Russian people had to go through. And my heritage, I'm actually half Ukrainian, half Russian. So my mom's side of the family is half Ukrainian, half Russian. And then my dad's side of the family is actually mostly Ukrainian. And you just think about, I'm from the southeast part of Russia and Sea of Japan. Like, how did my family end up from Ukraine in the southeast part of Russia? And the things that my grandparents had to endure, I'm very grateful for. The things that my parents had to endure with the breakup of the Soviet Union and being able to bring our family here to the US, I'm very grateful for. But if you look at the lifestyle element, we love our sauna, but then we pair it with vodka, and pierogies, but pierogies paired with sauerkraut. And the smoking. So I don't, it's very interesting. We could be the healthiest people, probably inside and out and mentally and physically strong. But we have these really bad habits like the smoking and the alcohol and just holding on to stress and previous trauma that's not healthy either.
It's so interesting that you say that. So my neighbors are all Ukrainian and they actually did my driveway. But the hardest working people in their 60s, like doing concrete work and just getting on their hands and knees in the sweat and just dripping sweat all over. And I don't see 20-year-old American men working as hard as these people like 3 times their age. So it's just really hard, gritty
Work ethic. I mean, I inherited my parents' work ethic. It's like I might not be the fastest or the strongest or the smartest, but man, I will do whatever it takes. Oh, sorry. Yeah. I will do whatever it takes to, get the job done.
Amazing. Love that. And so your website, if folks are listening to this in iTunes or Spotify, if I want to connect with you?
Yeah. So I have two websites actually. So my clinic website is Proactive Health ND. Okay. And then my personal website is Dr. Elana Zinkov. So I'm doing a lot with trying to educate women through my online courses, helping them understand hormones better, ranges, what to ask their provider about, how to test, what kind of therapies are available to them. A lot of things that you and I have talked about even here. And then, of course, I mean, I'm on Instagram all the time. I love the community that I've built there, and I try to inspire women and also educate them about their options.
Yeah, that's really important. Well, thank you for coming on the show and sharing such great wisdom and knowledge and actionable sound bites and takeaways. I think people got a lot out of this. So appreciate your knowledge, Elana. Appreciate you coming on.
Thank you so much. It's been a pleasure.
Thank you.